And this kind of vouchering system, is it something that is being used globally, or is it just here in Kenya?
There's a global recognition that inequality is a phenomenon that's here for some time, and it, in fact, is an interesting side effect, if you will, of globalization. That as economies improve, not all boats are lifted equally, and that there are some who do better than others, and that this relative inequality that opens up as economies grow, as countries' economies mature, requires then interventions that are also operating on that same area, and identifying mechanisms to target subsidies, healthcare subsidies, educational subsidies, providing a way to effectively reach those who maybe are not benefiting as well as others in better economic times, are strategies that will certainly generalize and be quite useful across many areas, many regions.
And when the voucher gets to the clinic is then able to claim back the money on the basis of the voucher, so there's an incentive to the clinic?
Yes, that's a very good question. So do facilities use the subsidies, or what sort of subsidies do they receive? And in this case, the voucher is both a demand-side instrument. It's generating, let's say, new users in the health system. It's also providing a reimbursement back to that facility. So if one's thinking of allocating a health budget, it can be done either as an input-based approach, in which drugs, supplies, staff salaries even, building construction, is allocated from a government budget into the production, if you will, of healthcare. One could also think about turning that around and putting those subsidies or that budget allocation on the output end. So thinking about redirecting spending into the results produced from a system, in this case purchasing, essentially, units of produced healthcare.
Demand.
Tying it to demand. And so investing these reimbursement subsidies, so what happens then, yes, to answer your question, the subsidies, there are service cost reimbursements made to providers that essentially direct government allocations to where the demand is. It more dynamically, more mimics what a market, in fact, is a market. And allocates government resources more along a market mechanism.
So if a clinic gets more patients, essentially they get more resources.
Yes, quality adjusted.
Yeah, and are there difficulties in the system with fraud or gaming the system that makes this slightly less than perfect?
Yes, this is no silver bullet. It's certainly not a panacea for the region. But it does offer some practical solutions to some current problems. That said, yes, fraud is a challenge, as it is with any system. Providers, like many, or other actors within the system,
is there any calculation as to, people do calculations of, how much corruption takes out of spend in, particular developing countries? Is there data that would lead you in that direction?
The nice thing about this is that there are data. Because money is tied to the output, program managers are very keen to track that. And I'd have to go back and double check the figures, but they're in the neighborhood of 2 to 3% of all voucher claims presented are rejected.
Right.
For questionable reasons. Either it wasn't completed properly or it was questionable in some way. So they're rejected in that measure. There are also ways in which one could spot irregular trends for claims that have been accepted. But the figure that comes to mind is 2 to 3% of claims rejected outright.
Okay. The other issue is that the healthcare is being delivered by 3 different kinds of providers. Private, NGO, not-for-profits, and the government, the public sector. Is there any data or research on the different performance of those 3 sets of providers?
It's a very good question. So do different providers perform differently? And we're seeing some differentiation, or yes, there are data around how they allocate their revenues. And the nature of the public sector here in Kenya is such that there's a requirement that the facility that receives these voucher reimbursements be able to then forecast their financial requirements over the next 2 quarters. And so monies cannot be spent immediately. These new budgets that now have to incorporate the voucher revenue, these budgets have to be approved by previously district and now probably the new counties. Before those monies can be spent. So there's a lag. A different dynamic in play. And that results in different priorities. Now, public sector also provides publicly funded staff. And so the sort of expenditure patterns that one finds in private facilities don't necessarily copy or play out the same way in public sector.
So what are the relative advantages, do you think, of those three different types of provision?
The advantages of each sector, well, there are different advantages to each. The public sector has more financial control over what's happening across a network of facilities. However, in the private sector, this autonomy, the ability to act on the revenues received at the facility level, allow managers to be more dynamic in procuring
and to respond
services.
more quickly to
Presumably.
To circumstances.
Yeah.
And the NGO, not-for-profit sector, what are the...
NGOs there are relatively few number of providers involved, both on, say, the secular nonprofits and the faith-based organizations. But the ones that we see in the scheme, they act more like private providers in many ways.
And if this type of demand-side provision was to increase considerably, so in other words you were targeting a range of different services, whether it was health or whatever, what do you foresee that the public policy issues would be that would begin to emerge?
It's quite interesting because in Kenya, one of the innovations with the voucher program in 2008 was that the government created a line item that allowed the Ministry of Health to procure services. And that allowed the voucher program to essentially expand using Kenyan taxpayer money. That is a public policy innovation that we might see generalized to other sectors. One could imagine greater service procurement based on outputs in the future.
In education, maybe? Or
in education, perhaps.
Yeah. And what do you think the issues are that come from that? What do you think the kind of distortions you might find occasionally in the system?
Well, there are a lot of new needs that emerge. Ones that are there now, but become ever more demanding or more salient if these reforms are to be enacted or this sort of approach taken. One, of course, would be this issue of simply tracking the outputs and making sure that the reimbursements claimed match with what's actually happening on the ground. So a greater emphasis on verification, both from an actuarial perspective, making sure that the books balance, but also from a service delivery perspective, being on the ground, being in the communities and sampling on a regular and rigorous basis that the services claimed are in fact being delivered. And as these programs grow, there's going to be an ever greater need for that sort of thing. And I think there's also a need for the public to be cognizant of the fact that although there are challenges in fraud control, fraud abatement, if one thinks of it, but I recognize that even in OECD countries, that globally, let's say in the global health sector, fraud exists in the range of 5 to 6% of all global health expenditures. Now, when we talk about the global health sector, it's several $1 trillion. I can't remember the figure immediately off the top of my head, but it was about, of that multi-trillion-dollar sector, there were $250 billion worth of fraud each year. Tremendously big figure. But we're talking about a tremendously big part of the global economy. And that amounts to roughly 5 or 6%. All of this fraud in the global health economy.
But presumably that average, being a global average,
yes,
conceals considerable variations.
It conceals considerable variation, true. It also excludes many of low-income country economies because there simply weren't data available, because the systems don't allow for tracking fraud systematically. And so I think one of the challenges going forward will be for countries like Kenya to better account for fraud, not on a project basis, as often happens now with donor monies, but to do it systematically.